Hey, can you hear me okay, Margaret?
Mhm.
Okay, wonderful. Happy New Year, everyone. Thank you for joining us for our January webinar. I am Malati Balasundaram, a neonatologist and one of the FCC Task Force co-chairs. For those of you who are joining us for the first time, I would like to extend a warm welcome and remind all attendees that a recording of this webinar and all slides will be published on our website, fcctaskforce.org. and shared in a follow-up email, which we encourage you to share widely with your colleagues and networks. We are excited that you are here with us and can't wait to learn from our amazing two speakers today. Today's agenda is for Morgan to briefly go through FCC Task Force work, and then I will introduce our first speaker, Liz, and followed by a 10-minute Q&A. And Morgan will introduce Terri, and there will be a Q&A after our session as well. So if you are not speaking, please mute yourself and please chat in your questions or raise your hand and unmute yourself and ask your questions. And with that, I will hand it over to Morgan.
Thank you very much. Happy New Year, everyone. Today's webinar honors Terri Major-Kincade's sister, Bridget Major, who was born at 26 weeks due to severe IUGR during a time when her parents were restricted to visiting on the weekend and peeking at their daughter through a glass window. Thank you for sharing your family's story with us, Terri, and for using their pain to improve care for NICU families. This work wouldn't be possible without our esteemed organizational partnerships. We'd like to welcome Colorado Perinatal Care Quality Collaborative and Define Colorado. Thank you for the quality improvement work you do both to center NICUs, families in the NICU, excuse me. I'd like to acknowledge Mead Johnson Nutrition, whose mission is protect, heal, and nurture in pursuit of a healthier world. Thank you, MJN, for sponsoring this webinar. As a reminder, we follow the all-in meeting guidelines as created by our very own Jennifer Canvasser's Next Society. For those of you who are attending for the first time, we use first names to address one another to break down the hierarchy and empower everyone to contribute. Please take a moment to review our webinar etiquette. We ask that you mute your microphone when you aren't speaking, that you turn off your camera if you're multitasking, and that any questions and comments spoken or written in the chat be respectful, non-discriminatory, and non-judgmental. We appreciate your help in making this space as safe as possible. As we move on to FCC Task Force leadership, I'd like to acknowledge that our organization is led in equal partnership between healthcare professionals and family partners, which is one of our key strengths. Malathi Balasundaram and Colby Day are practicing neonatologists, and Kira Sorrells, founder and executive director of the NICU Parent Network, and myself are former NICU parents. Thank you to our family partners for your contributions to our work. I love that we are diverse in our infants' gestational ages and diagnoses, and that we represent birthing and non-birthing parents, bereaved parents, and even adult preemies. I'd also like to thank our healthcare partners for their time and support. It's rare in our local units to witness such authentic collaboration between the various disciplines of practice you represent, and we appreciate that you embody our key strength of equal partnership between all healthcare professionals and family partners. Join us in welcoming Jessie Barnes to our Executive Council of Healthcare Partners. Jessie is a clinical nurse educator and neonatal outreach coordinator in Georgia and has a 2-year-old daughter who was born at 27 weeks gestation. We are excited to have you on our team, Jessie. The FCC Task Force is supported by its subcommittees, co-chaired by one healthcare partner and one family partner, respectively. Daphna and Alex of our Marketing and Communications Committee manage our social media accounts. Please take a moment to follow us. They do a great job of sharing our work and events and news taking place in the NICU FCC space. Myself and Vargabi collaborate with a variety of contributors to publish a quarterly newsletter, which includes actionable takeaways, and advocacy committee co-chairs Carrie and Nicole keep our task force working toward big picture initiatives like zero separation and unlimited access to parents and family caregivers in the NICU, and are currently heading the creation of a toolkit based on the internationally recognized PRESENCE study. As we head into 2025, we are excited to have added an Equity, Diversity, Inclusion, and Belonging Committee to the FCC Task Force. Co-chairs are Jessie Barnes and Mia Malcolm, both of whom are dedicated to and experienced in this most important work. Mia and Jessie will be providing an EDIB lens to our work to ensure health equity is a priority in everything we do. I'm happy to share that as of this week, we have over 1,800 members from 48 of 50 US states and Puerto Rico, 8 of 10 Canadian provinces, and across 63 countries. As the person who updates and measures our membership regularly, it's incredible to see the dedication to FCC in the NICU become a truly global movement. We've presented 17 webinars so far, with this being our 18th. Please utilize our webinar database located on our website under both the webinars and resources tabs to view and share all past FCC Task Force webinars. We encourage you to share these widely with your colleagues. Our January poll is geared towards supporting units who need more information on how they can be screening NICU families for mental health. Please answer our one-question survey to help us collect data on your unit's best practices. I'll be including the poll link and the link for all past polls and responses in the chat. Now I'll hand it over to Malathi to share some information on our NICU FCC Measures REDCap survey and introduce our first speaker.
Thank you, Morgan. So some of you already know, I just wanted to share this information with the new members. The FCC Task Force Executive Council created a comprehensive survey to measure FCC in the NICU and assess whether we are truly delivering FCC. It focuses on 7 categories. If you are not familiar with this work yet, please watch the video link that Morgan will share in the chat. And if you want to receive the survey link and register to receive it using this QR code on the slide, within 3 months of launching this survey, 69 centers participated to assess their unit FCC practices. I'm so excited about this, and I can't wait to look into the data. Next slide. This pie diagram shows the distribution of the 69 centers' locations within US states. We have received 8 international centers responses as well. As you can see, we can do better on the left side of the pie, so we need your help. Next slide. This slide shows the centers' names that have completed the survey. If you work in one of those NICUs, kudos to you and your team for your commitment to FCC. If your center's name is not on this list, there is an opportunity for you to be an FCC advocate. You collaborate with your physician or nurse leaders, or if you are a leader, then recruit a champion to complete the survey to assess your center's FCC practices. So if you have any questions around this centers or anything related to the FCC task force, please reach out to me or Morgan. And with that, I will leave this slide on the screen so you can take a look at that and see if your center's name listed or not. And I will introduce Liz for first speakers. I had the pleasure of getting to know Liz Rogers and her work through CPQCC Executive Council. She is a neonatologist and co-director of the Intensive Care Nursery Follow-Up Program. She specializes in neurodevelopmental and behavior pediatrics for critically ill premature infants. and other at-risk newborns in the intensive care nursery of UCSF Benioff Children's Hospital. I enjoyed listening to the discussion about early skin-to-skin care for less than 26-weeker in the Canadian Premature Babies Foundation preemie chat. Liz was one of the panelists. So she mentioned this phrase, and instead of saying, "We don't do that here," asking, "How could we do that here?" Be curious. So I invited her to share her expertise. Liz, thank you for accepting my invitation. The floor is yours.
Thank you so much to Malathi and Morgan and all of you. It's truly a fangirl moment to be amongst many of you here in the FCC task force. And I will say I did go back to my email, and it was last February 2024 when Malathi reached out with her invitation to join you. And I thought, I don't know if by 2025 they'll even want me to talk still, but here we are, and time is moving quickly. So I'm thrilled to be here. And those of you who know me know that I have a lot to say. And so I am going to be trying to get through quite a bit of content quickly in hopes that it sparks discussion. If there's anything that we're not able to really dig into in the slides, you'll have the slides for reference afterwards. And again, I hope those of you who know me, and I see a lot of familiar names and faces in the participant list, know that I'm always available by email and happy to move this conversation to other venues should we need to. So I'm thrilled to be here to talk about really optimizing organizational culture and mindset as we think about providing neuroprotective care and using skin to skin as a great example of a target for neuroprotective care and family partnership. I want to acknowledge that today is a day of quite a bit of uncertainty and loss for many in our community and beyond. And while I was watching President Carter's funeral and flipping away to visions of quite a bit of destruction in Southern California, I know that many of you have also been impacted, and many of our colleagues, friends, and family. So I want to take all of that into account as we think about learning together today. And also say that I often provide a perspective disclosure that I think is really important in every talk I give. One is that one of my major identities is that I am a mom of 4 full-term infants who have their own expansive and unique identities. But my experience in the NICU was only with my youngest, and my colleagues cared for her. And yet even a brief stay in my own unit really changed the way that I look at our family's experiences. I also acknowledge that I have many different roles through the CPQCC, our NeoBrain QI Collaborative, through the Vermont Oxford Network, All Care is Brain Care Collaborative, and that this is one key partner for me in Dr. Bonifacio, who many of you know, but just to acknowledge how much I've learned from so many of you in this room beyond the hundreds of centers I've been able to interact with through VAUGHN and CPQCC, and that so much of this learning, while I'll base it in our own center's experience, comes from hearing and learning from so many of you. So I have an ambitious agenda in the next bit of time that we have, but one is to really convince you that culture is an important thing for us to think about and be intentional about creating when we think about really improving neuroprotective care for our patients. To understand skin-to-skin care as a really important quality target for improvements in both family partnership and neuroprotective care. To ensure, as I've been hearing about the collaborative, even just in the last 10 minutes, that equity, justice, and sustainability are intentionally built into the culture of neonatal neuroprotective care. And then my biggest goal in life is to really get folks like us to consider how we know things and how different people bring perspectives and different ways of knowing into these rooms that we share together. And that is really important as we think about getting change implemented. So although I am a clinician scientist, I really view that as a platform to speak to those people out there who need to join your choir in the FCC task force. So I know I'm in a friendly audience today, but I always think about how to make these messages expand more broadly and have more reach. And of course, as you know, we're really here grounded in providing care for one of the most fragile populations that we could provide care for. And this is an old picture, but I think one that continues to express the great vulnerability that we all enter into during neonatal critical illness. And I want to frame this somewhat differently as we think about moving into care paradigms or care cultures, that our care extends to ourselves, our colleagues, our families, and obviously our patients. And again, as I think a lot about neuroprotective care, and to give us a framework so that we're all thinking about the same thing, we know this is a really vulnerable time. I often share pictures of the developing brain to really drive that home. But so much is happening, whether at birth for a full-term infant undergoing stress or therapeutic hypothermia, or an extremely preterm infant, that the brain is undergoing such diverse processes of maturation that some people view as areas and domains of vulnerability, but that we also need to reframe and see as a myriad of opportunity to protect the brain and to protect really the creation of a new family. Such that when we talk about surviving and thriving, and understandably, we've been focused on survival very much in our field, and survival is not unimportant, it's very important. And yet, how can we shift and start thinking more about thrival, this word that I've coined that I insist must continue to be used as a noun. But that every interaction with an infant and their family in our care setting is an opportunity to be brain focused and have a direct impact on the developing brain. And that has been the foundation of much of the neuroprotective work I've done, both in California and really across the country and world. But how can we make this leap from survival to thrival and really combine both? And those are the things that I really think about when I think about sustaining change and really thinking about culture and mindset. So how can we encourage ourselves and each other to take leaps, to take risks, and create cultures of change and growth? And as Malati mentioned, I often think about this and present this. Many of you have heard of the educational philosophy of growth mindset, which is that we need to reframe failure and that we grow from mistakes rather than being sort of stymied in our efforts to be creative or think expansively or be curious. And so this has increasingly been used to think about growth mindset cultures, not just growth mindset individuals. And I think that's extremely important because in order to really sustain and inspire a growth mindset individual, you have to have a growth mindset culture. And this can be viewed in many different aspects, but I really distill it down to this very idea of a fixed mindset saying, well, we don't do that here. A parent who's just given birth to a baby at 23 weeks and hearing, well, we don't hold skin to skin this early. Your baby is too unstable. We don't do that here. But how could we just reframe that to a question of curiosity? How could we do that here? And opening up to possibility changes the whole mindset of your organization and certainly of your relationship as we enter into partnership to care for infants. What is culture, though? When I talk about culture, it's important that we're thinking about the same concepts. And I think it's important to really view organizational culture as complex, but as shared beliefs, perceptions, and values in an organization. But to call your attention to this iceberg, because what we often refer to as culture are these things above the water, which are the way we say we get things done. We have chief strategy officers, and we talk about shared values or structures of work. We talk about policies, and we set really public goals for what our organizations are going to achieve. But we often neglect really the foundational aspects of culture, which are the way that we really get things done. And those are the unwritten rules, the stories, the feelings, some of the norms that aren't acknowledged, that are really held deeply in bias. shared assumptions that aren't outright said, that are sort of unclarified expectations. And so how can we bring some of this below the water iceberg to the forefront as we really think about developing a culture whose foundation is stronger, more transparent, and allows for growth? And this is from the business world, but I think, again, there's a lot of focus on strategy. And so I find it, I love this quote that really culture trumps strategy. Culture eats strategy for breakfast. I think it was Steve Jobs, but other people say it was someone else who said it. But it really is important as we think about the work that we set out to do together and whether we can really achieve continuous improvement in a place where we're not acknowledging some of this foundational structure, or sorry, culture. But where does culture come from? Where do some of these things come from? And I think this is also important for us to think about, that it comes from formal statements of organizational philosophy, charter, creed, some of the things we heard from Malathi and Morgan. You've set your organization with a strong shared culture right away as you sort of read about the mission statement, for example. And those things are important. Also, how your organization is designed and structured, systems, procedures, those things. But also, really critically, how leaders allocate rewards, status, resources. We know that resources can be scarce, and where do we put funds to support work? That's very important. What leaders pay attention to, what they choose to manage and control, and what they opt out of. How they react to critical incidents and crises. How they role model, teach, and coach. And how they recruit, select, promote, retire, and excommunicate. So this is from Shine, who's well known in organizational culture work. And what you'll see here is this word leader a lot. And that's why I aim to really speak to organizational leaders, because I think that they really hold the key to a lot of change. And yet we focus very much on grassroots efforts, and they are important. How can we connect our grassroots efforts with those people who really hold the sort of purse strings and the links to a lot of what our culture is perceived as? And to emphasize that we are all truly leaders. And so what we do and what our behaviors are when you think about how our reaction to crisis, or how we role model for others, whether we're leading our families or our teams at the bedside, or more broadly, a unit and beyond, that we are all leaders and our behaviors are important in terms of establishing culture. I'm going to talk about some specific cultures that we experience and come into play in the NICU, and how we can really optimize those to improve outcomes. So the first is this culture of neuroprotective care for everyone, or all care is brain care. The second, obviously, I'm here, and I'm not going to spend as much time because this is the foundation of all the work you do, but families as partners. True, authentic partners. And this third one, just to challenge us a little bit, and we'll get to it, I hope, the third culture of care, which is caring for our caregivers. So first, to think about all care is brain care, or this culture of neuroprotective care. We really view it and have been using these domains in our Vaughan 4-year arc of all care is brain care as protecting the maturing brain, preventing any acquired injuries, promoting positive sensory experiences and relationships, all of which really prepare a family for long-term thrival. And I'm going to use skin-to-skin care. Oh, well, this is a way of culture. This is our small baby program that it really requires getting so many people across so many disciplines to share values and to share vision. We were quiet. We weren't screaming, I promise. I really do believe that skin-to-skin care is a great model of neuroprotective care and family partnership together. I also tell families and staff all the time that it is one of the most evidence-based therapies in all of neonatal care. It impacts such a broad array of outcomes, both for the individual infant, the birthing parent, the non-birthing parent, and our whole unit culture, and as we go out to society. So skin-to-skin care is just such a foundational practice that I think is a great target for improvement that can meet so many goals that we share. I'm going to go over this a little bit quickly in terms of trying to get through some more content, but I don't think this is new to anyone. But skin-to-skin care has long been employed, centuries as a means of providing warmth, stimulate milk production. It's utilized broadly across the world. It was recognized first in the 1970s as a medical intervention, likely because high resource settings had created the incubator. And so what was the response to that? And certainly colleagues in Sweden and Colombia, excuse me, that's spelled incorrectly, Colombia, have really redefined this as a key outcome and indicator of quality care. And in Colombia, the initial studies of kangaroo mother care, which is another version of skin-to-skin care, really aimed for 20 hours a day and showed a 70% of reduction in mortality. And so it was in 1996 that kangaroo mother care was coined by a group working with the WHO. And since then, you'll hear a lot of different terms. And I think it's important to think about these all have slightly different connotations, just like family-centered care, family integrated care, families as partners, all have slightly different connotations. Ultimately, they are rooted in the same philosophy, and the same is true for skin-to-skin contact, skin-to-skin care therapy, known as kangaroo care, kangaroo mother care. An important study recently looking at the practice of immediate kangaroo mother care, or IKMC, which I'll talk about briefly. But ultimately, again, rooted in this philosophy of decreasing separation between parent and infant. And in term infants, it's been shown to promote breastfeeding, regulating heart rate, respiratory rate patterns, as well as in preterm infants shown to reduce mortality and infection, promoting breastfeeding, leading to better weight gain, as well as a myriad of other outcomes. The IKMC trial that came out just a couple of years ago and published in the New England Journal of Medicine was a multi-centered trial of over 3,000 infants across the settings you can see here. And it showed that intermediate kangaroo mother care, or the practice of going skin to skin, either on the birthing parent, non-birthing parent, or a surrogate, reduced mortality significantly. Also showed several different positive outcomes, as you can see here, and importantly, I would say a lower incidence of sepsis, and definitely supported the supposition that, and this idea proposal that skin to skin of low birth weight infants was safe and feasible, as well as showing clear positive outcomes. So this really prompted the WHO to focus on the provision of early skin-to-skin care as a clear target to reduce newborn mortality across the world. And yet, here in highly resourced settings, we are often behind our colleagues globally because we rely on technology. And so this is something that I think we have a lot of unlearning to do to really meet the example and the role modeling of so many of our colleagues across the world. There are a lot of myths. I'm actually gonna, again, I wish I could go over all the evidence. There's so much evidence. Go do your PubMed search on skin-to-skin care. There are so many myths about why skin-to-skin care cannot be performed in a sick or unstable newborn. You'll see here, these are just a few that you might hear in your unit, but this baby is too sick. The parents are too nervous. We can't maintain neutral head position. It's not in our IVH bundle. It might lead to unplanned extubation. We just don't have enough staff to transfer safely. I will just tell you, again, I have a whole talk on this you can find probably elsewhere, dispelling each of these myths, which is not to say that everyone should endeavor to jump in tomorrow if your unit is not one that regularly provides skin-to-skin care for less than 26-week infants in the first 3 days of life. Don't go doing it tomorrow. What I really hope I'm telling you is you build the culture and you will be able to do it. So despite all this evidence, why are there barriers to providing this evidence-based therapy that's been shown to improve outcomes for infants and their families? And I think there are a lot of reasons that we should really think about this in our own practices, and I'll give you some ways to do that at the end. And I want to acknowledge one important practice that's been studied really well by Dr. Scala and the group at Stanford, which is to look at, we don't offer it equitably to the many, many families who would benefit. And in particular, in this study, they used socioeconomic status and a composite. Some of you might be on the call today, but a composite representing higher and lower socioeconomic status, as well as a non-English language preference. And families who had a non-English language preference or who spoke a language other than English did not receive the benefit of kangaroo care as frequently as those who did. And that's just unacceptable. And so there are many barriers to providing this care, and there are barriers to providing it equitably, and we have to talk about them in order to really combat them and break down those barriers. So I'm going to tell you a little bit about how we've done this and approached this at UCSF, acknowledging very much for me and on behalf of my many colleagues at UCSF that we are still learning, iterating this and trying to improve all the time. And you'll hear that as part of this story. In 2017, we launched our PREME project, which is focused on improving care of our preterm infants less than 28 weeks. And one of the key things we found in reviewing the evidence was that our skin-to-skin care policies and guidelines were significantly out of date and not commensurate with the evidence. And so we actually had written that skin-to-skin care was not allowed for infants less than 72 hours. So we actively worked to change those guidelines. And then we're able to show that we increased our skin-to-skin care provision within 72 hours from 7 to 84%. And this has been published by one of our amazing nurse practitioners. And it was really achieved through, again, a unit-specific protocol, working on the strengths we knew we had, but also addressing the gaps we knew we had, widespread education for echo techs, for radiographers, for our x-ray techs, for all of our consultants, for our nurses, our providers, et cetera, and developing a checklist that families could go through to see whether their infant was ready and whether they were ready. Over this time period, we also showed a decreased and sustained decrease in our IVH rate. So we were showing that it was safe to provide this care early. Unfortunately, as many of our efforts, this improvement was not sustained during the height of the COVID pandemic. And so then we had to be back to work. But just to say a little bit about that, we obviously used our QI methodologies, and you'll see how they matured over time when I talk about our round 2. But setting our SMART aim, identifying our primary and secondary drivers, and then really finding the target work that we needed to do, which involved a lot of education, engagement with families, preparation with a mannequin doll for all families so they could practice their standing transfer. Again, you can see this in our manuscript as well, and I can answer questions. But what we showed during that time period is our days to first hold decreased significantly. We decreased the variation in them, and so we felt really good about what we were able to achieve, focusing on this sort of in the pre-pandemic era. Unfortunately, as you'll see here, our rates started getting out of our goal range, and we started seeing much more prolonged periods of time before infants received their first skin-to-skin. And so this really initiated our involvement with the CPQCC NeoBrain Collaborative. So I was very grateful that my own center participated in the statewide collaborative that I also had an incredible opportunity to be helping to lead. And so, again, many people, a lot of multidisciplinary work to refocus on our skin-to-skin care. And these were our aims, important to set your goals in order to achieve them. Again, our driver diagram matured, and so did our work in terms of really looking at our potentially better practices and the interventions that we wanted to focus on, and then a really good way of monitoring our progress and our work using here our implemented in process and sort of next opportunities on our driver diagram. And again, unfortunately, I won't be able to go into too much detail, but wanted to show you how much we were doing in terms of really implementing developmental rounds. Some of you participated in NeoBrain, and so some of the tactics we were able to share you've seen before. And for those of you who haven't, we really hope to disseminate the work of NeoBrain at PAS and more broadly, so look out for that as well. But we really worked significantly with our family partners. That is me in a kangaroo suit, by the way, in terms of really engaging families to take an active role and to be leading this work and leading our efforts for care provided through touch. And so you'll see, although we still have significant variation, this is the great work of Katie Kramer, our director of QI in our nursery at UCSF in Mission Bay. But we've really had good progress, and we hope to continue to work on sustainability and sustainment of these efforts. And really, we are really thrilled that we were able to achieve a post-intervention median of first skin-to-skin exposure for less than 32-week infants at 56 hours. So how did we do this? Again, we were able to show great improvement, but really what we learned was that the multidisciplinary aspect was critical to our success. And when we thought about why we were able to achieve a bit more success and more sustainability in our second round, a lot of that we felt was because we had participated in significant culture change. And so how did we do that? In my last 5 minutes, we were able to, through both of our CPQCC quality improvement initiatives from 2017 through 2022, to participate in a culture survey. Data is really important and drives executive sponsors to devote resources in particular areas. So when we were able to participate in this score survey, now CPQCC has adapted it and we have our own culture survey that we use, we were able to really look at where our opportunities were in terms of our own local culture for improvement readiness. And essentially what we saw as well is that we weren't ranking very well in comparison to our California colleagues and neighbors. And so as always works, and I very much appreciate my Stanford colleagues, if I can say at UCSF, well, at Stanford, they're doing this, sometimes I get a little more support to do it. So, you know, healthy competition amongst friends, I think is, we can leverage to our advantage. But what we found is that we definitely had some areas of opportunity and growth. And so we focused on them through something that we called our culture club. And we focused on developing community groups. And these community groups were part of the intervention themselves, because these groups were working on the tactics that we needed to implement. So they were focused on teamwork, communication, leadership, and burnout climate. They had broad representation, respiratory therapists, nurses, physicians, families, everyone on each of these committees. And what we found when we were able to resurvey is, and this was in direct comparison to our other California colleagues, almost all of whom during COVID, understandably, had a regression of some of their quality, some of their improvement readiness scores. We actually made gains during that period. So we actually had decreased personal burnout. We had improved, excuse me, move this. We had improved safety climate significantly. Our safety climate, despite being at the peak of the pandemic, really improved in terms of how we were viewing it. And our improvement readiness really went up. So when I think about why we were able to achieve higher skin-to-skin care rates in version 2.0 and sustain them, I really think it's because of the culture work that we were doing concomitantly to achieve that. In my last just couple of minutes, I'm going to speak to these two other important cultures of care that I think will improve your skin-to-skin rates, your ability to provide neuroprotective care, and overall a sense of growth mindset in your unit, and that's families with partners. Again, I'm speaking to the choir, but certainly what we know is despite all the focus and effort we put on the work that we do in the nursery, so much of brain development happens when children are discharged home to their families and communities. And so that's where the real work is happening. So what I tell my trainees and my colleagues and my teams every day is if we can do nothing, what we should do is take the NICU, which is a very disempowering place, and make it a space for power for our families so that when they go home, they can advocate for what their families need. So we need to change how we provide care in such a hierarchical way. Again, I know, speaking to the choir. But this is a great model from Yarden Freeman and Jonathan Litt and others looking at the social ecological model of long-term outcomes and thrival for families. And yes, they are infant level care, but they are also family, hospital, neighborhood, state, national, world, global level care as well. So I invite you to really dig in. This is a great paper from Yarden and colleagues. Because after all, even though we think about these days when we are sad to say goodbye to some of our patients who are going on to thrive, for them, when they go home, it's their best day ever. And I just want to share one example. And again, you all are living this every day. But one example of how to really bring families as true partners, we were able to hold the North America Town Hall for IKMC. And you might recognize here some of the authors of that really landmark paper of IKMC. And they came to San Francisco late in 2022. And we held this town hall as a way of implementing IKMC, or furthering skin to skin care. But when I looked at this, and again, we were the only North America town hall, all of the other town halls held in Asia and Africa and South America, I didn't see as much of the family experience being represented. Instead, we had all of these amazing scholars and globally experienced folks. It was incredible to be able to host them, so much learning, so much data. A lot of practice as well about how to achieve IKMC. But we advocated to really bring in our family voice. And so we were able to achieve it throughout, but we really ended with the experience of this birthing parent and mom who also sits on our family advisory council, had a 25-week infant who we cared for in our nursery. And she really represented the family voice. And at the end, we ended this whole illustrious 2-day workshop in town hall by filming Athena a message from all of us because she was at school and couldn't join us. But again, we have the power to invite this into the spaces where we are invited. And I feel like that is how we leverage, that's how we leverage privilege. I am over time, but I really want to get to this. And this is this aspect. I do serve as the Chief Experience Officer in the Department of Pediatrics at UCSF. And what that means is I really look at how we improve our work experience. And I've been challenged by organizational psychologists I've worked with to think about culture. And we think about being patient-centered. And patient-centeredness is why we went into the fields that we went into for many of us. And yet, if we don't care for ourselves and the people doing the work, we will not provide the best care for our patients and families. And so building a culture where we care for ourselves and each other, and even putting us in the center, brings our families and patients with us. And there's a lot of evidence that's been shown that the modern practice environment makes our professional satisfaction as providers of healthcare more challenging. Neonatal medicine is particularly ripe for burnout. And so how can we combat this in order to turn around and take the best care of patients and families? This is a really busy slide, but it is just to tell you that provider well-being impacts patient outcomes. So essentially, this is looking at a meta-analysis of all these different studies that have looked at the different elements of burnout. Each of them, if there is a sense of increased burnout, increased emotional exhaustion, depersonalization, or a lack of efficacy, they all favor an increase in patient safety incidents. So it isn't selfish to be thinking about how to care for our workforce. It is critical to achieving better outcomes. Because a nurse who is burned out is not going to facilitate a 23-week infant being held skin to skin by their family. This has been adopted through the IHI and others in the quadruple aim. And I really believe that cultural transformation does really importantly include not just physician well-being, which is this specific model that I've drawn for you today, but all caregiver well-being into culture, so that all leaders view advancing the well-being of the people they lead or who look to them for leadership as one of their principal responsibilities. We need to provide the care, we need to measure it. There are very smart people like Sarah Hanley at CHOP and others who are trying to measure culture and to really speak that academic language so that we can get out of just our choirs and get beyond, so that we can talk about culture and the importance of it more broadly. So I hope that when you go home, you can think about, start positively. When does skin-to-skin contact or skin-to-skin care work well in my unit? What's the scaffolding we've built that really, when it works well, it is humming? That's my timer to say to stop. And then after you can really leverage those positives, is think about what are the barriers in our daily practice. And for each one, utilize those QI methodologies, use those 5 whys, use your fishbone to think about how can we get to the root cause to break down these barriers for providing this important care for infants. Not, we don't do that here. Rather, how could we do that here? So being intentional about culture, I think, will be one of the key ways that we improve long-term outcomes. There's no silver bullet. And we have to learn and unlearn in order to do this and really represent the knowledge that all of us bring to the care of infants. Most importantly, their families. And women's soccer and women's basketball. There were
Thank you,
63 tabs,
Liz.
and I couldn't see. I'm sorry.
No, you did it. Thank you. Thank you, Liz. It's a fantastic presentation, and I loved it. And so if you have any question, please unmute yourself and ask Liz. And I did see one question from Rachel asking about your data. You mentioned is less than 28 weeker, you improve the skin to skin care. How low the gestational age goes? And do you have a different criteria for the gestational age for 23 weeker and 24 weeker?
It's a great question, and I do think one that requires quite a bit of further study. We do not take anyone out of our data based on gestational age, and so we are including every infant. Now, we're very transparent about this. At UCSF, we provide active care for all infants based on family wishes and shared decision making, starting at 23 and 07 weeks. And so we, I think, and acknowledge very much that 22, 23 weeks, these kids are in a slightly different category, and I think require some more study. But we currently include them in all of our data, and we have really good ability on high frequency jet ventilation. They are held, and they are held successfully without unplanned extubations. And so, yes, so we don't have a lower limit at the moment. But again, acknowledging that I do think that that's an area, a population that requires a bit more study.
Okay. I'm just screening through if there's any other question.
Yes. Hi,
Yeah.
I didn't see the hand icon to raise my hand, but I'm Dan Huang, a neo from Brooklyn Methodist Hospital in Brooklyn, New York. Thank you very much for your talk. And this is something that I've been trying to wrestle with at our unit, and we're going to start out with this, low-hanging fruit with the big babies and work ourselves down until people really buy in. But what I've been struggling is with those small babies. And I think the 22, 23 will be separated, but even 24 to 526, how early is too early, or is there too early? Because I've been asking around all over around the world, different units, and there are many people who tell me that they don't even do it until 2 weeks because of the concern, as you said, of IVH and whether this is too stressful, skin, fragility, all those other things. And so I was wondering, how early do you do it? Do you do it immediately? Do you do it 24 hours, 48 hours, 72 hours? And are there parameters that that have to be met to say, yes, this is a safe way to do it? We actually made a video to help ourselves, to help parents and the nursing staff and the respiratory staff learn how to do this so that they're not as concerned. But yeah, that's the worry, is how early, how soon can you do it when they're that low gestational age? And then would you be open to sharing your slides?
Always, for sure. And I think Morgan will make sure they get out to everyone. So first of all, I really appreciate your question. And I think what you really need to do for all quality improvement is really assess where you are. Where is your unit now? What capacity do you have now? What are some of the easy wins you can achieve to bring more people on board so that you can start pushing your own envelope? So understanding your local context and culture is super important. For some people, like, we're really pushing right now, our initiative is to join the many colleagues out there who are doing skin to skin care on high frequency oscillatory ventilation. We've gotten the jet figured out, but we really need to figure out the oscillator. But it sounds like for you, you really need to focus on those 28-week stable infants, maybe getting it done as soon as possible. And so for some people, it might be reducing the gestational age. For some people, it might be looking at the degree of respiratory support. For others, it might be reducing the time of separation and really bringing that down. But I would say start with where you are. What are the barriers that you've put in place in terms of organizational policy, and get those out of the way? Then think about those other harder barriers that are part of your culture in terms of attitudes, psychological safety. Seeing so much of this, and engaging in a broad sort of stakeholder engagement together to really understand where everyone's coming from. I will say, and I see Courtney on, thank you. And Courtney can speak to this. What we really learned in NeoBrain in our CPQCC collaborative was much more than I was appreciating. Our families have real fear. They didn't want to be part of something that they created an unplanned extubation, situation, or it's scary. There's so much fear. We've created so much fear around everything that skin to skin, it was just something for some families was just too much to contemplate. And again, for others of you in this room, you counted the minutes until you could put your baby to your chest. So how do we meet everyone where they are? And I think what we need to do is be clear about what the data tells us, and then be clear about where our own barriers are, take them out of the way so that we can move forward and make progress. I will say what we found was we were so focused on the littles that are like 28 to 32 week infants were not getting the skin to skin that they needed. And as soon as parents wanted to start putting them in cute onesies and like meet those milestones that are really important, they stopped getting skin to skin care. So now we've sort of shifted to our bigger babies in some ways.
Yeah. Thank you, Liz. And thank you, everyone. If you have any other question for Liz, please put it in the chat so she can answer that. And we are moving on to the next speaker, and Morgan will introduce Terri. Thank you.
Hi, everyone. We just had to invite Terri to come and present after hearing her podcast on the incubator. So welcome, Terri. Terri is a double board certified neonatologist and pediatrician with over 23 years of experience in neonatology, pediatrics, health equity, perinatal health disparities, and neonatal perinatal palliative care. A native of Baton Rouge, Louisiana, she holds a BS from Prairie View A&M University, an MD, MPH from UCLA School of Medicine, and is currently based in Houston, Texas. Dr. Terri completed her pediatric and neonatology training at UT Southwestern and UT Houston, and pediatric palliative medicine training at Baylor College of Medicine and Texas Children's Hospital. Her national partnerships include work with March of Dimes and the Pampers Womb to the World Advisory Board. Dr. Terri is a two-time Amazon bestselling author and recently released 2 children's books about life in the NICU. She looks forward to the day when every baby is born healthy. She especially loves mentoring future clinicians and is a champion of self-care, work-life balance, and the power of writing your own story. With that, I'll hand it over to you, Terri.
Thank you. If you guys can see my face, I'm smiling so hard. I just feel like I'm on a retreat with all of my people this afternoon at work. So I'm super excited to be here with you guys to talk about something that's near and dear to my heart. So I'm going to go ahead and get started so we can have time for some robust discussion. Next slide. So I have a couple of objectives today. I'm going to this is normally a 2-hour workshop about empathy and communication, and I'm going to try to do it in 30 minutes. And there are a few points I want to hit, and hopefully most of this will be familiar to everyone in the audience. I really hope that all of us who really care about family-centered care leave with just a reintroduction to the back to basics of what is really involved when you're developing a relationship with someone and how you build rapport. And even though we're using NICU families as our case example, these are concepts we should be using with anyone that we are trying to develop a relationship with and build some rapport and establish some trust. So we're going to go over some core principles of empathy. We're going to talk about some barriers that are unique to the NICU setting with respect to providing clear communication. We're going to talk about how those principles show up in our care. And then hopefully leave with 3 tools for empathy at the bedside. And I'm hoping that those of you who go back to the NICUs this week, if you see some of these mistakes being made or an opportunity to introduce a new tool, you feel comfortable sharing that. Next slide. So Morgan shared a little bit about who I am. I like pictures to usually go with that. And I always like to kind of like point out, Morgan shared I went to UCLA. And my favorite thing about going to school at UCLA was that I met my husband in Los Angeles during my 2nd and 3rd year of medical school, and he was a dancer on Soul Train. So for those of you who are old enough to remember Soul Train in the audience, that was his first job after high school. Like Liz, I always like to have a little disclosure. I am a proud mommy of 2 children who are the products of healthy pregnancies. I've never experienced a loss in the NICU. I don't know what it's like to lose a baby. My children have never been sick or in the hospital. So that keeps me very humble. And every time I walk into the NICU, I am looking to see what families can teach me. The middle picture is a picture of me deciding to go back to fellowship at age 54, 3 years ago after being a neonatologist 23 years, because I really wanted to spend a year learning how to formally develop my communication skills. Although I felt like a very good communicator already, parents and staff told me that I was, but I really wanted to go back for training. And I see it as a ministry and a way to partner with families in the NICU, being a bridge to make sure that their wishes are honored. Next slide. So Morgan gave a shout out to my sister at the beginning. And Morgan, you made me cry because I forgot we had talked about that. And I sent my sister a quick text. So my whole life, I've wanted to be a neonatologist. And the way I got introduced to preemies was my sister, who was born in 1968. She was born 3 years after President Kennedy lost his son to prematurity. For those of you who are able to old enough to remember, his son was 35 weeks and 5 pounds. His son was not a very tiny preemie, but his son was born before we had surfactant and before we had level 3 NICUs in the US. His son was actually life flighted to Canada to be treated. And as a result of that, it started the development of NICUs in the US. And my sister was born 3 years later and able to benefit from that. So I'm always humbled by that. My sister was very sick. My parents were told she was not going to survive. They could only visit on Sundays and they could look at her through a window. She did not have a name the first 3 weeks of her life. They simply referred to her as baby girl Major. So both of us today, well, can I share my age? I think I can share my age. I'm proud of my age. I'm 57. I don't think I look it. And my sister's 56 and she is healthy. But it was the time where parents couldn't be in the NICU. So my mom's fascinated by all the things that parents are able to do in the NICU now and wonders how her journey may have been different if they had been able to do that. Next slide. So communication, I love this quote by Dr. George Bernard Shaw. The single biggest problem in communication is the illusion that it has taken place. And I cannot tell you how many times I go into the NICU and I'm talking to families who are frustrated about miscommunication, breakdown in communication. And then I talk to the teams and the teams will say, but we talked to them for an hour, but we had a family meeting, but I talked to them during rounds. And this happens quite commonly. And I will share that I recently presented at an AAP meeting about communication, and it was a room full of 200 or more pediatricians, neonatologists, and nurse practitioners. And I simply asked who in the audience had formal training in communication. And I want you to know that about 30 people raised their hands. So most of us are doing it on the fly and getting better as we go. And most of what we've learned about how to communicate better, we've learned from our families. Next slide. So what are the barriers to effective communication, particularly for those of us who work in an intensive care setting? So there's been a lot of study looking at just the nature of rounds. And rounds in and of themselves are not actually set up to maximize patient care and communication, but it is how most of our families receive information. So one of the biggest barriers is the location. So do you work in an open bay unit or do you work in a unit with private bays? Does the team round with a group of 8 to 10 while the family is at the bedside, or does the team round without the family? And so most of the units I work in, the family is incorporated into rounds, but at my hospital, it's a 150-bed NICU. The teams are 8 to 10 people pushing computers around and incorporating families. So that in and of itself doesn't lend itself to the intimacy that we would like to have when talking to our families. What about the timing? What about the timing that we speak to families with respect to the clinician perspective? When do we talk to families about updates? Often we talk to them during rounds because that's what works for us. But is that the time that works best for the family? Would a time after the family has a chance to take a break, come back, process be better? Is evening better for families? Should we have a team that's really dedicated to give updates during the night as opposed to the on-call person who may not know the family as well? What about families who have language and transportation barriers? All those families don't get the same access to communication that other families receive. And then what about the family perspective? I love that Liz said the NICU is a very disempowering environment, and the family often has no control over the way the information is received, how they're going to receive it, when they're going to receive it. Next slide. So why is it especially important for these families? I'm going to talk a little bit about the nature of the NICU environment and this concept of it being disempowering. Next slide. So this is a very unique population with unique problems. And normally when I tell somebody what I do, and they go, oh, you take care of the preemies. I tell people that when I'm going to work, I know I'm going to meet somebody every day who was not planning to meet me. I am going to meet somebody every day who is not happy to meet me, nor should they be. This is an unexpected, unanticipated event, and that is how the relationship starts. How many of your relationships start with you being forced into a relationship with someone you weren't even truly want to meet that day, but now you got to be stuck with them 3, 6, 9 months? That's how the relationship starts. So there's a potential for chronic sorrow and serial bad news. Every day that you walk into the NICU, you're not sure what you're going to receive as a family or how it's going to be delivered to you. Or even when you feel like you have the information, you may find out something incidentally from another team member because someone else didn't share. Or you may have access to Epic and see some results that weren't discussed with you. So there's a potential for neglect and bias that's embedded in the NICU. And I love that at the end of Liz's talk, she mentioned that there's so much focus on the tiny preemies that there was less focus on the bigger babies. And there's actually quite a bit of research to show that bigger preemies families often feel neglected because of the way people say to families, oh, it's so wonderful you have a bigger preemie. Oh, it's so great that at least they were 30 weeks. Oh, lucky you, they're 32, they're 34, they're not 22. Nobody feels lucky about being there. Obviously, they understand that, but they don't feel lucky. Potential for multiple delays and long-lasting complications. So that is embedded in the environment in the NICU, even when we're doing the best family-centered care. Next slide. So why is it like a war zone? So parents often describe it like a war zone, or they describe it like a roller coaster. So just like a war zone, you have the potential to hear something upsetting every day. You're surrounded by noises and alarms, sickness, and sometimes death. The family next to you may be there one day and not be there the next. And like a war zone, you don't know who's going to go home healthy, who's going to go home with challenges, who may not survive. So there's a potential for serial trauma. So I learned very early in my career about the risk for PTSD in families who have babies in the NICU, and I was surprised, and I am excited to see that the Family-Centered Care Task Force is focusing on this behavioral health issue because it's a resource that's very woefully lacking in many of our NICUs. And we know that the risk for PTSD, people have the belief that the families that have the smallest babies or the families who are in the NICU the longest have the highest risk for PTSD, but that is not true. The research would suggest that it's related to the coping style of the family. And the way we learn the coping style of our family is to build rapport. They have to trust us enough to let us know what they need. And so we know that family-centered care, mentor groups, and shared decision-making have all been shown to be helpful in mitigating parental distress. Next slide. So I love that we're going back to Stanford today. This study is very old, but I got exposed to this study when I was a brand new attending, and I was excited about two things. That men were included in this study with respect to the way their PTSD shows up, and to have some tangible evidence. Since that time, there have been many, many studies, but this is one of the original studies that looked at families after a NICU stay. After 4 months, 3 had symptoms of PTSD and 7 were at high risk in the Stanford study. And in the Duke study, it was a set of 30 parents, and after 3 months, 29 had 2 of the 3 markers for PTSD, and 16 had all 3 markers. So I want you to think about that as we think about empathy, that we're engaging in conversations with people who may be navigating how to manage the PTSD of just being there to get this information. Next slide. So this is a more recent study. I said that there were a lot more since then. So this is from 2023. And in this study, they were able to show that up to 1/3 of families experience some symptoms of PTSD related to the entire NICU experience. So we have some work to do. And I think that can begin with improving the way we speak to our families. Next slide. I just wanted to put this up again because I just wanted to emphasize, if you look at the literature for very low birth weight, bigger preemies, babies who are over 28 weeks, 32 weeks, who may have a NICU stay between 4 to 6 weeks, one of the recurring things we have learned from families is the perception that they're lucky or that it's no big deal, can contribute to breakdowns in communication. And when there are anticipated problems, it's very hard to kind of bridge the gap when you've told someone they're lucky to be there. Next slide. So what are the ABCs of empathy for NICU parents? So I said we were going to go back to basics. We're going to talk a little bit about acknowledge. We are acknowledging that this is the beginning of the relationship. We are establishing a relationship. We are meeting someone. Breathe. Breathe means something a little different than what you may think. And I have a little quiz, a little poll for you guys. I want to see how you respond. And then curiosity. And Liz kind of mentioned about using curiosity and having open-ended questions instead of, we don't do that here. How can we do that? And I'm going to talk about how we can use curiosity in engaging our families to make sure we are having a two-sided conversation. Next slide. So how do we acknowledge parents in the NICU? Next slide. So the first thing to establish rapport in any relationship is the introductions. How are we going to refer to each other? What are our names? How are we going to greet each other? What language are we using? What posture? And are we asking permission? And I will admit here that prior to going back to do this pediatric palliative care fellowship, I had never asked one family, is this a good time for you? Is this an okay time to talk? Because we are taught to just go to the bedside and say, hey, I got something to tell you. And unless you look like you're having a bad day, we deliver our news. And so giving people control in an environment where they often have no control is so empowering. And when I think about how much control we take from families in subtle ways that becomes cumulative, I can see how it manifests when we have to talk about really hard stuff. So let's talk about introductions. Next slide. So when you greet your families in the NICU, are you saying, hi, mom, hi, dad? Are you using first names? Are you using Miss, Mr., or Mrs.? Are you asking families how they want to be addressed? I will say that I was taught during my entire pediatric training that parents want to be called mom or dad, and that parents appreciate this because they may not get to hear it again. So they want to be called mom or dad. And so we have more evidence now that families actually don't always want to be called mom and dad. Just like any other relationship, it should start with, how should I address you? How should I address you? How should I say your name? How should I address you? How do I pronounce your name? And so when I went back to do my fellowship, the first 3 months of my fellowship, I want you guys to know every day I got a bad evaluation because my attending would say, you did a great job talking to that family, but you called them mom. I'm like, I've been saying mom and dad for 24 years. Like, it's not going to go away like overnight. But if you've been taking care of somebody's child for 3 months, 4 months, 5 months, 6 months, you should know their parents' names. So in this, the previous slide was a slide that was a blog that went viral, where this mother detailed all the reasons why she did not want strangers to call her mom, why she didn't want people older than her to call her mom, and why she didn't want people who were not her actual children to call her mom. And that was really very eye-opening, but shouldn't have been surprising, but it was very eye-opening for me. But depending on where you practice and how long you've been in practice, you're probably around a lot of providers who still call all parents mom and dad. And when you call everybody mom and dad, I just want to just say here, I want to name here that that does not personalize that relationship. And think about your other relationships. Are you in any other relationship where outside of your immediate family, people are identifying you by the role you carry in your family? Are you out in the world and people are saying wife, husband, sister? No, they're not. Next slide. So in this one, don't call me mom, how parents want to be greeted by their pediatrician. And 88% of families, this is a more recent study, wanted to be addressed by their name, and only 14% of providers did so. So think about being in an ongoing relationship and you're actually not being addressed the way you want to be addressed, but you're having to have conversations every day about the care. Next slide. So this was a breakdown between residents, attending physicians, and nurses. And I mostly want to draw your attention to the never. So they were asking caregivers how often members of the inpatient team addressed them by their preferred name. So for residents, 23% of the time, the resident never addressed the family by the name they wanted to be addressed by. For attending physicians, 28% never did. And then for nurses, only 11% never did. So I think there's some work that we can do there. So this is just the beginning of empathy, establishing rapport and making sure we acknowledge and greet families who we're going to be in a relationship with the way they want to be greeted. That's the first way you empower someone, addressing them by the name that they would like to be addressed by. Next slide. So the next is posture. So we actually have great data to show that just taking the time to sit down instead of stand looking down at someone while you deliver information creates empathy. And if you actually sit down with someone and talk to them versus stand up and talk to them, when you come back and ask patients who spent the most time with you, patients' families have the belief that the person who was sitting spent more time with them, even if they didn't. And so the graph here, you can see that the provider actually spent a total of 1 minute sitting and talking, and then 1.1, almost 1.5 minutes standing, but the families felt that the person who was sitting spent more time with them. In the NICU, most of the time, it does not lend itself to being able to sit down. Our teams are big. We don't have enough chairs. It's very crowded. But the dynamics are very different if you're sitting looking at someone eye to eye, as opposed to looking down at someone. And so these are a couple of pictures. The bottom picture, everybody's standing. So the ability to impact a power differential is less there because everybody's standing. But when you're standing up looking down, it's very different. Next slide. So when I was researching for this talk, and I'm not sure, I know we have people attending from all over the world, I was very fascinated by this protocol from one of the hospitals in the UK where they have parent-led NICU rounds, and they provided the sheet that they use, and the parents actually lead the rounds, present all the updates, and guide the questioning. And I was, how can we do that here? And if you look at these pictures, everybody's sitting. You see the dad with his hand on the chest talking about the updates. You see him leaning forward for clarification. You see dad and the medical team smiling at the end. And one of the things they point out is often when families have specific questions, we might say, oh, well, let me take a moment and look in the computer. Oh, when was the last eye exam? Oh, when was the last, oh, when did they get transfused? The parents actually know. The parents actually know all this information. They're the most consistent providers, as everybody here knows. And so we need to make sure that they are incorporated in the rounds. They're part of our team. They're not visitors. And everybody here knows this. But when you see opportunities to be more inclusive in the way we interact with families, try to do so. I actually had an attending that actually walked around with a chair like on her shoulder so that she could cop a squat like a camping chair whenever she was talking to families. And I mean, I'm almost 60. If I sit too low, I may not be able to get up. But I was very impressed that she was that committed to it. Next slide. Asks permission. So this is one of the things I said that has been life-changing. So often, you know, we have emergencies in the NICU. We have to give the update right then. But if you really want to create empathy, if you really want to build a relationship that's built on mutual trust, honor boundaries, honor a trauma-informed approach, and ask permission. Is this a good time for an update? Is there a better time that would be good for you? Maybe a better time is when their partner is off. Maybe a better time is when they can go pick up their kids from school and come back. Ask them, give families some control in that, and don't necessarily presume that this is the time to hear more bad information. They get a lot, or good information. They get a lot of updates from many teams, and to assimilate all of this information is just helpful. And often families will say, oh, yes, it's a good time. But sometimes they'll say, I'm going to go get a coffee. Is that okay? I'll be right back. I've had families say that. I was like, please go get the coffee. So just ask permission. So we're going to acknowledge, we're going to introduce, find out how families want to be addressed. We're going to try to assume a sitting posture, and we're going to ask permission if it's an opportunity to ask permission and it's not an emergent situation. Next slide. So B, breathe. So I'm going to just say it again. B, breathe. And breathe is a reminder to us, and I'm intentionally talking slower. B is a reminder to us to embrace silence. Next slide. In order to create empathy, you have to allow space for silence. You have to allow space for people to process their emotions as well as interact in the conversation. And so my poll for you guys, if you guys can put in the chat, how long do you think, I'm going to say physicians because that's the data I have. How long do you think physicians wait before they interrupt families who are talking? Tell me how many minutes, seconds y'all think the physician waits before they interrupt the family talking. Michelle, thank you for typing so fast. Okay, 10, 15, 30. Oh, God, somebody said 2 seconds. Oh, wow. Okay, 10, 1. Okay, I love you guys. I said this to you are my people. So, all right. So you guys certainly have been in rooms where we're trying to establish rapport. We're trying to have a sacred space for sharing. And while somebody is processing and sharing, they just pop, the family may pause just for a second. Somebody jumps in, or they're talking and they're cut off because there's an agenda that needs to kind of be completed or a plan that needs to be discussed. So next slide. So no surprise to most of the people in this group, but studies have shown that patient normally speaks for an average of 18 seconds before they are interrupted. But also if you let the patient, the family speak for just 3 to 4 minutes, they usually will tell you 90% of what's wrong, their worries, and what they really want to know. And a lot of times what we're talking about on the medical team may not actually be the family's biggest worry. And when families are coming to family meetings or when we are asking them to rearrange their schedule to talk to us, we want to open that meeting with, we have some things we want to talk about, but what's most important to you? What are your goals for this meeting? Because you want to make sure you address it. So the next time you guys are in a family meeting, I challenge you to time yourselves. I have my residents and fellows time the different attendings. We actually have a chart of how long people are able to embrace silence and look for opportunities so that we can make sure that families have the opportunity to feel equally included in the conversation and that we have a way to build a bridge for rapport. And for those of you who are in relationships, think about how many times you pause before you interrupt your partner. Like this applies for us outside the NICU as well. Next slide. So remember when we're talking and if we're trying to embrace empathy, emotion is first. The emotional part of our brain connects first. And we have to allow time for processing, slowing down so that the cognition can catch up, so that we're able to have a conversation where people can make decisions for their child that is most in line with their views. Next slide. So remember, hearing is passive. Hearing is passive. It requires no effort on your part at all. You're sleeping, noises wake you up. You're trying to do your work, your pod mates distract you. You're in the NICU, you hear all these alarms and noises. Listening is active. Listening is intentionally pausing, embracing silence, allowing someone's emotion to catch up with cognition. Listening is also nonverbal. So your nonverbal, your posture, your gestures, your facial expression. So we are hardwired to listen. We are hardwired to listen up to 500 words a minute. But speaking, we speak 125 to 225 words a minute. So we're actually hardwired to listen. So give yourself permission to embrace more silence and give our families permission to share more and have permission to lead those discussions. Next slide. So how does it show up in the NICU? How do we know we're hearing and not listening? One-sided family meetings, you leave a family meeting, the team talk the majority of the time. The meeting ends with, do you have any questions? And often when you end with a question like that, the answer is yes or no. And you want to end with an open-ended question. Do you have any worries that we didn't discuss? Is there anything you were hoping to talk about today that I didn't discuss? Can you share more with me about what your concerns are? Make sure we end with open-ended questions. And then negative labeling or stereotyping. So we label, sometimes families that are strong advocates are labeled as assertive, aggressive, as opposed to being a strong advocate for their child. Sometimes questions are perceived as mistrusting the medical team, when really the family is trying to get more information to make the best decision for their child. And then a perception that a family is in denial rather than understanding the value of hope or the fear or worries they may have about a discussion. And I love that Liz mentioned that families have a true fear sometimes about doing kangaroo care. And so we want to be able to make sure we are listening, that we're not judging, that we're not labeling, that we're embracing silence so that we can create a space for true empathy. Next slide. So how do we stop judging and listening? We started off in Liz's talk, she said, change your statement from we don't do that here to how can we do that here? And when we're talking to families and we learn new information, we want to follow up with tell me more. Thank you for sharing that. Tell me more. Help me understand your concerns about this procedure. Help me understand your concerns about the care your child is receiving. What are you most worried about if we change the formula, as opposed to this is our standard of care. This is our bundle. This is what we do here. This is our policy. How can we build a bridge to allow listening and not just hearing? Next slide. So we've talked about ABC. We've talked about acknowledging ways we're going to acknowledge this relationship. We've talked about breathing, really embracing silence, taking time to embrace silence. And then we've talked a little bit about having curiosity. The best way we have empathy in action is really immerse ourselves in taking the perspective of our families. For some people, taking the perspective of someone else, having empathy is bringing them Kleenex. Bringing somebody Kleenex is actually not how we show empathy. And sometimes bringing Kleenex means your tears bother me. So I want us to go a little deeper and think about how we're going to make sure we take the perspective of our families so that we're partnering in shared decision making. Next slide. So this cartoon, I love this cartoon. It talks about making sure you are able to see it from somebody else's point of view. So same cartoon, the first one, somebody stranded on an island, he's saying, yay, 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 boat. The person on the boat who's been stranded is saying, yay, 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 land. The shark is saying, yay, food. And so when you're talking to families who have a different perspective or who have different wishes or different values with respect to how they want to navigate care for their child, you want to be able to pause and put yourself in their shoes. We want to make sure that they are partnered in the care. And if we don't understand the perspective, invite them to share the perspective, because I can guarantee you, when given the opportunity, families are able to share that very clearly. And it's really the main thing my team does in supportive medicine is a lot of perspective taking to kind of bridge breakdowns in communication. Next slide. So how does perspective taking look for NICU parents? So the way I often see perspective taking not happening in the NICU is when we're having to bring up conversations around technology. If we're recommending a G-tube versus trach and families trying to navigate that choice. If we are talking about monitoring for apnea and how we feel like the apnea should be monitored and how the family can navigate fears around going home. Perception of visitation. Families who visit during the day or who are there during the day are often perceived differently than families who are there at night, and very differently from families who only visit on the weekend. So what is the perception? What is the perspective of that family before we label families worries, fears, commitment, and advocacy, because we don't see them during the time we are rounding, which was the time that was convenient for us. And then feeds, families who are navigating going home with NG feeds, giving the child more time to practice bottle feeding or getting a G-tube. There are different perspectives that that really inspire those values. And do we allow space for different values and different choices? And we want to make sure that we do. And then the micro preemie versus the bigger preemie versus the term baby. and how our biases impact how we interact with those families and how we interact with their worries around their child. You know, sometimes people will say, well, why are they worried? They have a 36-weeker, they're fine. No, they're not fine. They're in the NICU. They need to take this is a different experience. So let's try to see it from their perspective. It's still an experience that was unanticipated. It's still an unexpected experience, and it's still a different journey that requires the same type of support. Next slide. So the other way we take perspective is recognizing emotion in another person. So those of you who typed seconds in the chat, how many times have you been in a meeting, or you may have been in a meeting yourself, and you felt like your care team could not read the room? And so I often encourage people to just spend a little more time reading the room. And so on the left side, I have different expressions for babies. And when we have more time, I usually have people, I have the picture up there and I have people write down what the emotion is they think they're seeing. At the bottom, those are adults. And it's really interesting how many people between anger, disgust, and fear can kind of get confused with the emotional expression. And if we're not sure and we can't read the room, the best way to find out how to support a family is say, can you share me a little bit about what you're feeling? Can you share a little bit about what you're feeling right now? Or can you tell me what is most upsetting? You may think what's most upsetting is the news about the brain. There may be something else that's more upsetting to the family than that, like they didn't get to hold today when they were promised that they would. So you do want to ask about what the emotion is that you're seeing, but you want to allow space to name it, because remember, emotion must be attended to first and then cognition second. Next slide. So when we validate what we see and we name it, we build rapport, we build a bridge. So when families have this extended, thank you for sharing what's most important, I can only imagine how hard this is for your family, as opposed to your baby's doing fine, discharge was canceled, it's just one more week. Would it be helpful to have another opinion? I often ask families, would it be helpful to have another opinion, even if I have good rapport? That is a way to build trust. Because if they know that we feel safe enough to invite another opinion, that's another bridge. That's another layer of intimacy. And the last thing I'll end with before we wrap up is making sure we validate you're a good parent. There's so much information that I'm sure everybody here is familiar with from the Courageous Parents Network and all the work that's been done with good parent beliefs and all the ways we can advocate for families by naming you are a good parent. Thank you for being so intentional. Thank you for your questions. Thank you for being so thoughtful. Thank you for telling us how that made you feel. We need to get into the habit actually of thanking families for letting us know when we need to do better. And I love it when a family comes to me and lets me know, because I know that there's been enough intimacy in that relationship that they feel safe enough to share. We can feel your love for your child. So these things are very validating. And we don't have time to talk about it today, but there is literature for some families, particularly for minoritized groups, in which they don't feel safe sharing when they don't trust, because they feel like if they let you know they're upset, then we are going to change the way we care for their child. So this is not a small issue, having safety to let you know when you have a difference of opinion. Next slide. So everything I've been talking about in terms of tools for creating empathy and building a bridge are part of something called the NURSE acronym. And so many clinicians have been taught spikes for difficult conversations. A lot of us haven't actually been taught tools for empathy. And so this is a very good tool for empathy. NURSE. Name whatever you perceive as the conflict or the breakdown in the communication. It sounds like, and if you're wrong, parents will tell you. Sometimes I will say, sounds like you're really angry, or sounds like this is so frustrating. And the family will say, no, I'm actually annoyed. Annoyed is actually a different emotion than frustration. And so if somebody says I'm annoyed, I'm happy, because that's another question I can say, oh, can you tell me what annoyed you the most? Because maybe I can figure out how we can fix that. So understanding, once you understand once you believe you understand what the family has shared, a way to solidify the empathy that's being created. Just so I can summarize to make sure everybody's on the same page, I believe I hear you saying this, and based on what you shared, our recommendation would be this. Get in the habit of repeating back just in case it's changed from what your original treatment recommendations are. Respect, again, honoring good parents. Support, we are here for you. And then explore. Tell me more about that. Tell me more about your concerns. Keep saying, tell me more until all the concerns have been explored. Next slide. So I just wanted to put the good parent beliefs up here because families, those of us who have children, we all have different things that are central to our core with respect to being a good parent. My husband and I both have things that are very different about what we need to make sure we're being a good parent to our children. And we both have very different views, and your views are based on, you know, how you're raised, your life experience, a number of things. But if you look at this, there are several different themes that kind of emerge with respect to what's most important for me every day when I'm in the NICU to make sure I'm being a good parent and partnered in the care for my child. So just taking a little time to review that. I won't review it today, but we know that families who feel affirmed as good parents are able to mitigate many of the challenges in the NICU better than families who don't feel affirmed. Next slide. So I mentioned that the reason good parent beliefs are important is because they manifest in the way you interact with your children. And the last thing I'll say with empathy is when we find ourselves having conflict with families because they have a difference in point of view about how they want treatment to happen for their child. For those of us who are parents, I want you to think about the way you make decisions for your child. We have two children. They're 24 and 26. I made their healthcare choices. I made their diet choices. We just selected their schools. Our daughter wanted to go to school on a college, a track scholarship. We regretted it later, but she did. That's a conversation for another day. Massachusetts was very far from Texas, and she had a lot of challenges. The way they participate in sports, their group, their friend groups, their choices. Nobody ever comes to me and says, well, I think Terri's in denial. I think she's in denial because she chose that for her child. I think she's in denial because she chose that for her son. I actually don't think she has her child's best interest. I'm not sure. And so we want to make sure, one of the ways that I try to build bridges for empathy in the NICU is just reminding those of us who are so invested in these families is that I am taking care of this child, but it's not my child. I am not their parent. And we have to center the family in the decisions. We have to do perspective taking. We have to hold space for different values that may be different than ours or different than what we believe we may do for our child if we were in that situation, even though we've never been in that situation. And so we want to make sure that is a big way that we disrupt communication and we disrupt empathy when our values are elevated as more important than the values of the family, who's actually been the person that's been there every day since the child's been there. And so, and I think sometimes we have to just step back and kind of remember we're not the parent and we're partnering in the care. And our job is to provide the best information in a safe space, in a space that honors the family to participate so that we can achieve what the goals are for their child and hopefully so that they can go home. Next slide. So this is my last slide. So just a summary here. I had originally had the little YouTube video from Brene Brown about empathy. And if you guys haven't seen it, it's about 3-4 minutes. Definitely go there, just Google it. It's a really cute video where she talks about the difference between empathy and sympathy. And she talks about the different ways that people who are not expressing empathy try to show sympathy so you can move through your difficult situation and so that we don't have to stay there long. But empathy is when somebody is really struggling and somebody is really having a hard time. Instead of talking to them from the hole above, going down the ladder and getting in there with them and being with them, bearing space, bearing witness, creating a safe space to listen, embracing silence, and not trying to minimize what they're going through and allowing them to kind of navigate the space to what the solution is going to be. Because often if people have the time to just embrace silence, they know what the solution should be. We just have to be there to listen and not just hear. So for empathy, our ABC is acknowledge, breathe, curiosity, the big A, introduction. Make sure you're not in a relationship with someone where you're actually not even addressing them the way they want to be addressed. the barriers in the NICU, just by virtue of being in the NICU, a private versus an open bay, the way we do rounds, the way we deliver information without asking permission. Let's figure out ways that we can navigate that if we are in units where there's work to be done there. And then empathy and action, our language, our posture, good parent beliefs, perspective taking, open-ended questions, not yes, no questions, and then the NURSE acronym. And I think the next one's our last slide, Morgan. That's it, my friend.
Thank
you,
you
guys.
so incredibly much. That was amazing. Both of you, Liz and Terri, just world-class presentations, just such great information. I do have one question if you've got time, Terri.
Oh, yeah, I have time.
Is there, have you seen data about language that feels condescending to parents? She said, sometimes I wonder if families wonder why we think we can tell them if they are good parents or not. And I worry that sometimes our intention in our language doesn't translate well. And I think that's totally valid.
So thank you so much for your question, Rachel. And if there are parents, if any of the parents who have NICU graduates want to chime in, y'all can too. I'm going to tell you what the literature says, but I am always intimidated when I'm actually in an audience of people who are actually NICU parents who can say, girl, no, for me, that did not work. So what I will, Liz, Rachel, the first thing I'll say is there is data. So for good parent, the actual language around good parent came from the Courageous Parents Network, and they have hundreds of parents in there who have children who are navigating life with technology. And for those families and the data from that, there's 3 longitudinal studies. It can be affirming because one of the fears when is particularly if you've made choices around technology is, do you think I'm a good parent because I made this choice for my child? Do you think I'm not being a good parent? Because often there are a lot of conversations about the choices families have made. So that language has been endorsed by many families. But I will tell you what we do have data for. When you're telling someone they're so strong. So particularly for minoritized populations, specifically Black women, saying to them, oh, you're so strong. You're so strong. And telling somebody they're strong when they are in the NICU, and by no choice of their own, one minute they're pregnant, the next minute they're in the NICU. I'm strong because I have to be. I showed up here because I had to show up. And you telling me I'm strong is not helping me right now because I actually don't feel very strong. And so I actually was in a family meeting and the chaplain said to a mom, you're so strong, you're so strong. And mom's like, duh, what other choice do I have? And so there's actually some literature around that. And my fellowship project was actually around stigmatizing language for parents in the NICU and the PICU. And in addition to words like strong, there are other words that we use that can be very stigmatizing to families, especially now that families, these words shouldn't have been in the chart anyway, but now that we have open charts, we have a lot more information. So for good parent, there's a lot of data around the good parent literature base for that. And honestly, anytime I've said to someone, you're a good parent, you're an amazing parent, I may have been working with the family a long time. Often the first reaction I get is tears. Like sometimes they can't even respond. They've been holding their breath, wondering how we're judging them and the decisions, the visitation, the decisions, everything. And often that may be the only thing I'll say in a meeting. And the response will be tears, and then later, thank you. But strong can be very polarizing. Morgan, I didn't know if somebody else wanted to.
No, I was just going to say that I have to imagine, Dr. Terri, that when you are speaking with NICU families and you tell parents they're good parents, it's coming from a place of authenticity. You're not just saying it to say it.
Yes, exactly. Exactly.
I think
Parents can tell if you're using a script.
You can't just say it to say it, right? Because people know when you're saying something that you don't mean, especially when you're in such a heightened state of emotion and vulnerability.
Yeah, I agree. Parents can tell if you're using a script. And so remember, we talked about listening includes nonverbal communication. And I can tell you the people who can read the room the best are the parents, the families in the NICU can assess a new provider, a new team, a new member in 5 seconds. In 5
Drama,
seconds.
conflict, all of it. We know.
Yes. I mean, I get all the scoop from the families. I'm like, okay, what happened while I was gone? Okay, wait, what? Okay, so.
Well, and I just I can't help but just jump in really quick because there's good evidence. Actually, there's been a great ethnography done by NICU parents that their perception of the team's relationships with each other impacts their perception of whether they think their baby is receiving safe care. So if they think that the team is in conflict with each other, they know, and they think that that makes the environment less safe for their infant. So it gets back to the like, get your own stuff together, team.
Yeah, yeah.
And it's so commonsensical, but it needs to be said out loud, right? Because we all need to understand it. Are there any other questions before we say goodbye? Thank you all so much again. We hope you'll join us for our next webinar taking place on Thursday, Thursday, March 13th. And we will look forward to getting all of this out to you in a follow-up email by Monday. Thanks again, Terri and
Thank you,
Liz.
everyone.
Thank you.
Thanks, Terri and Liz. Wonderful presentation. Thank you.
Thanks for all you do.
Thank you.
Thank you, guys.
Bye.
Do we stay on or we get to leave?
Oh,
You
we
get
can
to
we can leave. Okay.
Go put your feet up.
Bye. Thank you, guys.